Well, hello, everybody. I hope you can all hear me. My name is Amanda Ellison, and I am the Executive Director of the Wolfson Research Institute for Health and Wellbeing here at Durham University. So on behalf of my co-directors, our senior officer and myself, I'd like to welcome you all today to our latest public lecture. Our topic today revolves around issues that have not been addressed well in medical practice, something that we here at Durham University have been trying to change for over 10 years now. Following brain injuries such as stroke, there's a lot that can be done to restore a patient's movement or speech function. But if you lose your ability to see, well, there's been relatively little that can be done in healthcare. And the work that's been done to change this forms one of the strands in our Brain, Body and Behaviour Challenge Academy. We've been very proud at the Wolfson Research Institute for Health and Wellbeing to support the development of the solutions that you'll hear about today. And they've made a huge difference to people all over the world. So we have two speakers today. We have Kathleen Van Cleef. She's an assistant professor and NIHR Advanced Fellow in the Department of Psychology, who works closely with patients and clinicians to develop assessments of visual loss for better diagnosis and understanding of need post-brain injury. Alison Lane, an associate professor, in the Department of Psychology, will then tell you about the development of a tool that will train patients to compensate for their visual loss post-brain injury. Now, again, this development was ahead of its time, including patients and clinicians in building the app that Ali will tell you about. And it's unique in that it's free and can be used independently by patients in their own home, anywhere in the world. Now, Kathleen and Ali have a lot to tell you about, so it's absolutely time for me to shut up. Welcome, everybody. And again, I'm very much looking forward to this entirely stimulating talk by Kathleen and Ali. Over to you, Kathleen.
Thank you, Amanda. Yes, welcome, everyone. I'm looking forward to tell you a bit more about how we can detect vision and visual perception problems after a stroke. To get us started, let me move to my next slide. There we go. First question is, of course, what is visual perception? So how do we see? Well, to see, we need not only our eyes, obviously, but also our brain. Because when we see an image in front of our eyes, the eyes catch the light of that image, but that information needs to then travel through our brain before we can actually make sense of that image. And you can see it's quite a long distance, all the way to the back of the brain. And you can think about it a bit as sending a message. So the signal doesn't mean anything to you while it travels, but only when the message arrives, that's when you can start to understand it. So as long as this message travels, you will not understand there's a butterfly flying in front of you. So think of it as if someone is sending you a letter. So the letter is posted, it goes in the postbox, postman takes it around, delivers it to you. All that way, the letter is there, it's traveling, but you don't know what the message is. It's only when you open the letter and when you read it that you can understand. And that is that last bit, that is what the brain is doing. It is trying to understand these signals that are coming from the eyes. So the eyes, they pick up the message, but they can't make any sense of it. They can't interpret it. That is why it needs to travel to the back of the brain, where the brain then interprets this message. So we can do something with it. And that process, what the brain does, that is what we call visual perception. Visual perception are the different processes in our brain that help you understand messages coming from the eyes. So here you see an example of a glider. And this glider has very specific colors, but it's also moving through the sky. So the information that gets to your eyes and then to your brain is both information on color and information on motion. And in our brain, these different processes are processed in different brain areas. So different brain areas are specialized for different processes. So the process is specialized for color, the process is specialized for motion. And then later on, the brain brings these little bits of information together, and then we understand, oh, this is a glider flying from left to right, or whatever direction. What kind of processes are we talking about? So I already mentioned motion and color. There's also different shapes. Certain areas of the brain are specialized in recognizing shapes. There are areas specialized in faces or objects. So here you see a drawing of a brain. This is the back of the brain. This is the front of the brain. And here you see the brain from the inside. Here you see it from the outside. So again, this is the front and this is the back. So the message arrives here at the back and here, and then travels to the different areas. And there are two main pathways that we in visual neuroscience recognize, and that's what we call the dorsal and the ventral pathway. These are just complicated words, but what they basically represent is the ventral pathway. These are the areas of the brain that are really concerned about what are we looking at. So you can see here that this pathway goes at the bottom, and in the bottom you have areas that are really specialized in recognizing faces and objects. So you want to know what are we looking at. But that's not the only thing that's important. We are constantly interacting with the world, so we also need to know where things are. Can we reach it? Is it too far? Is this car coming towards me? Is it going away from me? And that is the where pathway. So that's more the areas at the top of your head, the top of your brain, that are specialized in that. When you have a brain injury, any of these areas can be damaged. So you can have problems with any of these in itself, or a combination of different issues. So I'll walk you through a few examples of what can go wrong after a brain injury. So some people will have visual field problems. Ali will tell you a bit more detail about that. But what it basically means is imagine you're looking at this scene. This is how most of us will see it. So you can see fairly clearly the houses, the cars, the street, the trees. This image is what doctors look at, and here you can see this fairly white grayish. That means that there's no problems, there are no issues. Pictures on this side have a dark area here at the top. That means there is this area of the visual field of the picture is difficult for this person to see. So as you see, it's a bit blurred out. So this is common after a brain injury, or sometimes it's the bottom. It can also be either the left or the right. I'm just giving two examples here where it's the top or the bottom half of the image that's unclear anymore. So that's something that can happen after brain injury. Another one is motion blindness. So that means that people can still see everything clearly. There's nothing blurred out, but they don't see anything moving. So they see it more the world as static images. So this is a video on YouTube that shows you a few examples. I'm not going to show everything of it, just the last couple of seconds to show you what it could look like if you have motion blindness. Another quite peculiar thing that can happen after a brain injury is what we call blind sight. And these people, they say they're blind, but unconsciously they still have some vision. So here is a famous psychologist with one of his patients who has blind sight. And as you can see, he put some obstacles on the corridor. And although this patient is saying, I can't see anything, he's still able to avoid these obstacles. He can't say there is a bin there, or there is, what is it, a tripod in the way. But somehow he does realize that he should turn a bit more to the left or the right, even though he's completely unaware that there are things over there. Color blindness can happen. It's a different kind of color blindness now we're used to. So usually people talk about red-green color blindness that some people are born with. But after a stroke, color blindness can be even more severe, so that you can't see any colors anymore, that everything becomes a black and gray. Simultanagnosia, it's a big word, but if you look at the different components, simultan, it sounds a bit like simultaneously, and agnosia is, excuse me, not knowing. So you can see things, but you can't see them at the same time. So we often give patients this picture, And they will be able to see the different individual things in the picture, but not bring it together. So for instance, they'll describe it as, okay, there's some water flowing, there's some wiggly lines, there's a child, I can see another face. So they can see the different parts, but only in isolation. They don't put the different things together and can see that actually in the scene there's a lady doing the dishes and some children in the background trying to steal some cookies. This is very challenging because these people also don't have any control over what they're looking at. So 1 second they might see this face and then they blink and that face is suddenly gone and they'll see water. So it's very confusing. Object agnosia, another YouTube video about a patient who explains it quite clearly. So I'll let him do the talking here. As you can hear, he has problems with recognizing objects. He can still see colors and things moving. So these areas in his brain are working fine, but the areas in the brain responsible for recognizing objects, that is difficult for him. Other people have problems not with objects, but with faces. So quite a challenging condition too. Where blindness is where people have difficulties recognizing words. So some people, they can still writing, so they can still write letters to their friends, but they have problems with reading the letters they get back. Oliver Sacks, in his book, The Mind's Eye, he describes a few of his patients with problems like this, including someone with word blindness, and it's quite an interesting read if you would like to learn a bit more about what it means in daily life. Good. So what have we done is, before I was working in Durham, I was in Oxford, and there I developed this visual perception screening test. So this is a screening test that really picks up these issues that people can have. Sorry, give me a second. So it's important that we pick up these different problems early on so that people can get the right information about what's going on, and that they get access to rehabilitation if that's available. And Ali will talk a bit more about what options there are. I developed it together with stroke survivors. So we really asked them what was important for them, make sure that the font and the colors and this sort of phrasing that we used in the test was clear and accessible. And it was also what exactly we are testing for and how long the test should be. That was all decided together with clinicians to make sure that it also really fits with clinical practice and it's a useful instrument. Here we go. So what does it look like? It has different tasks for people to do. So here's an example where I showed them a picture and I asked them, what is this a picture of? And they can choose from a few different options. This is an example of the tablet version, so they can tap themselves. But people sometimes, obviously, after the stroke, people have difficulties with using their hands. So it's also okay for a clinician to do the tapping and also do the reading if they have problems with speaking. Another task is where would you typically find this object? So this is a bit more difficult. The previous one, you had to recognize it, but here you also have to what we call link it to semantic information. You need to know not only what the object is, but also where you can find it and make associations. People need to recognize shapes in this task. So which of these shapes at the bottom is most similar to the one at the top? There is a task where they have to count stars. So for people with simultaneous agnosia, where they can only see one thing at a time, counting the number of stars is really challenging because they can't see all 4 stars in one go. People have to decide whether the line is tilted or not. They have to try and remember faces. And they have to, in this task, detect where the complete hearts are. So if you look carefully, you see that some hearts have a gap So people need to ignore those hearts and tap the hearts that are complete. And we also asked them to do some drawing, so copy this funny line drawing and read a paragraph of text. So with all these tasks, we try to measure a whole range of different visual perception problems that can happen after a stroke. To make sure that our test is doing what we expect it to do, we obviously need to know what is a normal score. So for instance, for the reading task, how fast does an average person of 70 or 60 years old read this paragraph? How good are people in recognizing those faces that we show them? So we did a research study where we asked healthy volunteers of a similar age as stroke survivors to do all these different tasks. So here are the different ages that you can see. So people between 20 and 100 years old took part. And this showed how many people of each age took part. So you can see that most people were in their 60s and 70s. And when you look at people who have a stroke, most people who have a stroke are indeed in their 60s, 70s. There are always people who are a bit younger, and there are also people in their 90s before they get a stroke. So we really want to make sure that it was a comparable group. So based on that, we then found out what is the minimum score someone needs to get to be considered a normal score on our tasks. Once we knew that, we could also really check whether it indeed measures visual perception and not something else. A common thing, for instance, is people, when they go to hospital, they don't always have their glasses with them. They might have been taken by an ambulance, and that is not a priority at that time. So we wanted to make sure that what we are measuring is indeed problems with visual perception in their brain and not problems because, for instance, they're not wearing their glasses. So what we've done is we asked people who had a stroke to do our test, the OXVPS, and we also asked them to do a gold standard test for visual perception. This gold standard test works very well, we know that, but it just takes too long. It takes about an hour. So it can't really be used with patients because it takes too much time with the therapist, and also many people can't concentrate for an hour shortly after they had a stroke. And we found that when you compare the two tests, that a new test picks up 85% of the patients with visual perception problems. So that's really good. And it correctly categorized 95% of the people who don't have such problems. So we're very pleased with those results. We also compared it to see how many people are picked up with the new test compared to how many are diagnosed in normal clinical practice and standard clinical practice. And standard clinical practice uses self-report. And if you look at self-report, only about 20% of the stroke survivors will tell their clinicians that they have some vision problems. While if we do a systematic screening with our test, it turns out that about 75% of the stroke survivors have such problems. So by using this screening test, we really pick up a lot more people who have such problems and can give them the advice that they need. Even if the problems are more subtle, that people don't notice them or report them spontaneously. We obviously asked clinicians what they thought of the test now it was finished and whether they would use it. So this is about a rating. So we asked them to give them a star rating, just like you do when you review something you've just bought. And most people give it 4 stars, and quite a good chunk of people even give it 5 stars. So we're very happy with that. So this was about 100 clinicians who gave us a rating. And we also asked them if they would use it, and all of them were very, we're looking forward to starting to use it. These are all the people who helped out with developing the test. I got support from the Stroke Association and Christchurch College, who provided funding for that. In the future, what I want to do is, so I'm now at Durham University, and the NHR is supporting more research in this area. So we want to make an even better version of the test and look in what we call diagnostic accuracy. So that's finding out how accurate it is in making a diagnosis. and also include more advice on rehabilitation. Because it's all well to find out what is the problem you have after a stroke, but then the next step is, of course, what can we do about this? So giving people appropriate advice is really important. And that takes me to Annie's talk, and she will be talking and focusing on the rehabilitation part.
So thank you, Kathleen, for introducing the fantastic assessment tool that you've been developing. And I'm Ali Lane, and I'm going to be focusing on the rehabilitation side of things. So rehabilitation tool that we've been working on in particular. So the tool that I'll introduce has been specifically developed for visual field defects. Hemianopia is the most common type of visual field defect following stroke, where 1/2 of the visual field has been affected. In reality, it doesn't really look like the image shown, because it's not like there's a black hole, rather it's just that the vision is missing. Visual field defects are a relatively common occurrence after stroke, and they can result in many behavioural problems in everyday life, which I like to separate out into problems with reading and then problems with various exploration tasks. And this can include things like finding items that you're looking for, finding your way around and navigating your environment safely, trying to avoid collisions and those sorts of things. Exploration is generally worse in busy, unpredictable environments, like a high street on Christmas Eve. But it's generally better when the person is at home and they can kind of control the layout of items and remember where they have actually placed things and use that as part of their search behaviour as well. These sorts of impairments can have knock-on effects for social and emotional functioning. When people are worried about always knocking things over or bumping into other people, then obviously they tend to go out less. That results in isolation and increased feelings of depression. And there can be additional impacts as well. For instance, reduced independence, reduced likelihood of returning to work, an increase in falls, and many more besides. The amount of visual recovery that someone can experience is debatable, but spontaneous recovery of the visual loss is usually limited to 3 months from onset, and typically only a small amount of lost vision actually returns. This means that for most people, they are left with chronic visual field loss that they then need to compensate for. And you might think that it should be easy to compensate, that the person should simply look into their blind field more often, but they don't typically do this. In fact, they frequently demonstrate inefficient searching eye movements. Their eye movements are slow, they're short, and they're disorganized. It's like they just don't know where to move their eyes next to find what it is they're looking for. And although patients with chronic visual loss typically have more organized scanning than people in the acute stage, their eye movements are still typically disorganized relative to normal. At present, there is no standard systematic approach to visual field loss rehabilitation by the NHS. So it seems very hit and miss, just depending on which trust someone is with, for instance, and even down to just the individual team that they might be under the care of. I would say it's better generally than it was when I started looking at these many years ago. How about we just leave it at that? But there are still individuals I encounter these days who are pretty much sent home with very little information or understanding of what their visual impairment is or options that are available to them. Various different approaches have been explored experimentally, and one of these is compensatory saccadic training. What this involves is simple eye movement training tasks that try to encourage people to develop larger, faster eye movements and to explore greater areas of that blindness with greater ease. And lots of studies have shown that this type of compensatory training can be effective. It can be used to improve searching behaviour. People are quicker to find things and they miss fewer items as well. And there's improvements in quality of life. People reporting benefits, what the sorts of activities they want to see improvements in, like shopping or crossing the street and so on. Recording of eye movements has also revealed that the training does lead to enhanced scanning behaviour. And also these improvements are persistent. And that's an important outcome when we're considering rehabilitation techniques. I'm going to talk you through the evolution of Drex, which is the product that we've been developing over the past many years. The first version of this was a computer training that focused purely on exploration. And it involved simple visual search tasks, like the example that you can see on the screen, where the idea is that the person looks around and tries to find a target that's defined by something like colour or shape. They have to decide if it's present or if it's absent, if it's not there, and then push a button to indicate their response. There's varying ways in which we can make the task more difficult. For instance, it can move further into the periphery. The distractors can become more numerous, and they can also be more similar to the target. So in this example, the yellow is relatively easy to spot hidden amongst those red X's. However, if that target item was pink, it would be much harder to spot in amongst those red distractor items. And also we can reduce down the amount of time that the search is actually presented on the screen for. And all of these sort of modifications to these specific parameters are designed to encourage faster eye movements, larger eye movements, and efficient searching strategies. Now, the earliest version of this training involved me actually adjusting those parameters on an individual block by block basis. I would try to do it so maintain accuracy of at least 80%. This would push participants to actually try and improve, but mean that the task never became so difficult that it was decreasing their motivation. And we ran a controlled trial and it found that it worked. Lovely. People got faster at searching, but there were some problems. First up, training specificity. Although it worked at improving exploration skill, it had no transfer, no benefit for reading tasks. At the same time, another researcher at Durham, Susanna Schutt, was doing looking at reading training. She had found the same thing, that if you train reading, you get better at reading, but not exploration. So these are two very distinct skills, very particularly in terms of the eye movements that they need. And to benefit both, you really need to train both. One of the other problems with this early version was that, okay, it was great, computer program, so you didn't need lots of expensive equipment, but it did mean me sitting with them, adjusting those parameters. And while I had a lovely time visiting people and drinking lots of tea, that's labor intensive. And it's not really feasible to expect, say, occupational therapists to be able to deliver something that's so time consuming. So we developed the training further. The second version involved a self-adjusting computer program, which meant that it no longer needed to be supervised. Patients could train in their own time, in their own home, and again, maintaining that sort of around about 80% accuracy. So tasks could get a little bit more difficult the better they got, but if for any reason their performance started to dip below, then the task would become easier again, always maintaining just enough to kind of be pushing them to get better. The lack of transfer between exploration and reading, again, meant that we wanted to try and train both. So we developed an additional task to try and train reading behaviour. So we used the same visual exploration tasks, visual search tasks for the exploration component, and developed a reading specific task. We wanted something that would involve them having to make fairly similar kind of cognitive decisions and responses. So we chose a task where they had to decide if words on the screen, a word on the screen or more words, if any one of them could be a word or a non-word. So you can see sort of an example here. Carrot is a real word, but the other two, carrot and larret, aren't real words. But they're plausible words. They are orthographically correct, if you like, letter strings. And they're very similar to real words. And that means that people have to read them really carefully so as to avoid any sorts of guessing errors. And just like with the visual search tasks, we can make the task more difficult or easier again. One way is to change the word length. The longer the word, you actually need more eye movements within the word itself in order to read the whole word correctly. So we can increase the length of the words. You can also add more words. So in its most difficult version, you can have 7 words presented kind of like a sentence across the middle of the screen. And any one of those could be a non-word. And that encourages eye movements not only within words, but between words as well. And once again, speed of presentation. We can speed it up and we can slow it down. Because all of this version of the training is unsupervised, it meant patients were in control of how and when they trained. And we found that on average, people would train for 30 to 45 minutes per session, 3 to 4 times a week. And that meant that they completed all of the trials that we needed within around about a 9-week period in our study. So the study did show, once again, that it worked. This time we saw improvements in reading and in exploration, and as well, transfer to quality of life. There was still a problem, if you like, with that version though, which was to do with ease of access. It didn't work on Macs, so patients had to have a PC, in addition to which they would have to contact me and I'd send it out on a CD. They had to understand how to install that training from a CD. You can imagine the sorts of barriers that all of this presented to people who are primarily older adults and may have limited tech experience, which is a fancy word Amanda and I generated ourselves. Limited experience with technology. We developed the training further to improve that accessibility, which led to final version of it, which is Drex, Durham Reading and Exploration Training App, free multi-platform app. Those basic tasks remain the same. It's visual search and it's this sort of reading task as well. But it's the packaging which changed to make it into a readily available system. Some of its key features, like saying multi-platform. You can use it on Android devices, iPads, and you can also access it through any PC through our kind of web online version. It means people can use devices that they already have. Tablets are also cheaper and more readily available. People can log off on one device and kind of log into another system, and all of their training will still be stored as long as there was an internet access in the first device. It's free, improves accessibility. Users don't need a permanent internet connection to just use the downloaded app. So again, that improves its accessibility because a lot of people might not have a permanent internet connection, but they might be able to go to their local library, download an app onto their tablet, and then go home and complete the training, for instance. Of course, because it's this multi-platform touchscreen, means that it's now an option with this version. And again, that improves its accessibility for novice users. Novice users much better able to quickly get to grips with touchscreen technology than trying to figure out a PC, for instance. The settings can be adjusted, so you can change what is recognized as a tap on a tablet, or the amount of training that somebody has to do in one individual block. That's especially helpful if people have any comorbid problems with something like attention or with memory. It means that they can do fewer trials in one sitting before having to take a break, for instance. If they forget what the task is, it's going to be less long before they get reminded of the instructions. So all of those sorts of versions or modifications have been made to this newer version. There are additional features too. There's a portal so that people can share their data remotely with a professional, healthcare professional, if they want to. There's built-in assessment tasks so people can monitor their own progress. We've got a YouTube channel, which has lots of like training videos so people can watch the videos if they struggle to remember or struggle to understand what a task is supposed to be. They can watch the training videos and figure it out. And all of these sorts of features were developed alongside those users to really understand the needs. And we did a randomized controlled trial to explore the efficacy of Drex training. 20 participants recruited to 3 different groups. We had 2 who were using some version of the Drex training. They were separated out into those people who were using some sort of tablet device and those who did it on a computer. And then we had a control group who received standard care. They were all assessed at multiple time points, baseline, after exploration training, after reading training, and then a 3-month follow-up period as well. Primary outcome measures, visual search as our exploration kind of skill. This task was where they had to find a number hidden amongst some non-number items. It meant that it was not a task that they'd been repeatedly trained on. So it wasn't simply the case that they were much better at recognizing yellow X's, for instance, but rather that it was their exploration skills that we were assessing. And reading speed, so doing some reading aloud and recording how quickly they would do it and how many errors they would make, so we could generate a corrected reading speed. There were additional measures as well, like quality of life, vision-related activities of daily living. This graph shows the improvements in searching behavior after training. And what you can see is that both of those groups who received the Drex training showed significant improvements, whereas the control group showed no significant change in their exploration behavior over the same time period. It's not a speed accuracy trade-off effect. Accuracy is typically very high on this task, around about 95%, and it didn't change significantly in any of the groups. So actually that approximately 30% improvement in speed is specific to those groups receiving the Drex training. This then shows the improvement reported or seen following training for reading. So this is the reading task. And once again, both of the experimental groups, both of the Drex training groups showed significant improvements in their corrected reading speed with no significant change for the control group. This time round, though, there was actually a slight difference between whether or not someone had trained on a tablet or on a computer. And the computer resulted in slightly greater benefit than doing reading training on a tablet. And we think this is associated with the stability of the image. The eye movements that we're training with reading are much more precise than those that we're training with exploration. And that means that if someone's holding their tablet, even a small amount of kind of wiggle or shiver or something like that could be enough to destabilize those eye movements that are needed for reading to a greater extent than seen with a computer task, for instance. So all of these kind of findings show that we have a Drex app and that it is effective. But what might the future look like? For me, the future is VR, I think. It's going to be more naturalistic, and that inevitably makes it a little bit more engaging. We can also train behaviors that people are actually interested in. Not very often is someone really looking for a yellow X, but they might be interested in finding their own car keys. Not their car keys, house keys probably. They're not allowed to drive, but their own house keys. But you can also train them on tasks like driving in a safe manner. It's a simulated environment. For me, one of the key features is that search isn't always purely visual. There's memory and logic aspects as well. If you're trying to look around for the slippers, chances are you're going to be scanning just the floor. If you're looking for the clock, it's probably going to be in the upper third of the wall. So you're kind of restricting around your search area using that information that you already have about where items are most likely located. And because search isn't therefore always driven by visual information, that sort of VR naturalistic environment allows much more of that integration of top-down kind of cognitive components of search as well. I'm also interested in comorbidities. So homonymous visual field defects like hemianopia can happen with few other cognitive or behavioral symptoms, but that's not always true. And as Kathleen mentioned before, there can be additional difficulties with other aspects of visual perception, for instance, or problems with memory or attention or whatever else it is. And I think we need to understand how training can be adjusted to suit the individual, to understand whether or not they can use their memory for kind of visually guided search. Do they have sufficient object recognition to be able to perform these sorts of tasks? or do we need to be somehow training all of those different aspects together? So in conclusion, there are many visual perceptual problems that are missed in current clinical practice. The tool that Kathleen's been working on, the OX VPS, can help with that underdiagnosis. It's as good as a gold standard test, but 4 times faster, and it picks up more subtle problems as well. And the Drex app is an accessible, effective rehabilitation tool for individuals with visual field defects. We hope to be able to continue to improve the electronic tools available, and thereby the assessment and rehabilitation of post-stroke visual and perceptual impairments. Thank you very much to all of our collaborators, our funders, and thank you all for listening.